Hi guys, this is Dr. Vishal Jain. I'm an endodontist, and today I'm shooting this what you call educational seminar from one of my series of endo courses, and this is the lecture which is a combination of standard textbooks, my own experience, and this is basically what endo is in modern times and how it is done and how it is to be done. So this is the same course which I teach in my clinical courses to my students, and this is I'm doing it for my fraternity, my dental friends who can go through it and learn more about the modern endodontics. So basically this is a complete course. You need to be having a lot of patience to go through it. It is not for somebody who's here for 5 minutes and 10 minutes and just want to learn and just get away. It is a full thing. So take out time, listen to the whole story. Don't leave it in between and then try to do some other thing. It is the complete endo, and it will clear a lot of your fundamentals, a lot of your concepts in clinical endodontics as well as your academic endodontics. So basically it is everything what you need to know. And my course is called as Endotronics. This is 8th course and 9th will be coming soon. But this is the whole thing. So I'm just doing this so that I can share my knowledge. I can tell people how it is done. I've done a lot of root canals in the last 10 years, and what I have learned through it, and what I've learned was the old endodontics with hand files or the understanding of pulp. Everything has changed. Everything has taken a turnover. And I didn't find any modern lecture on this, so that's why I'm making this for anybody across the world to see it and learn from it. And all of your comments are most welcomed. I hope it helps you out. So let's start with it. And I will just switch off this camera. It's not needed. So let's start. Something about me. I'm Dr. Vishal Jain, as I told you. I'm a graduate from Bapuji Dental College, from a master's in endo. Finished my master's in 2010 from GDCH Ahmedabad. I'm a postgraduate diploma holder in hospital and health management, and I'm a PhD student presently. So those are all my credentials. I'm also a trainer and mentor for Kerr Carvo Systems and Sensodyne, Abbott Healthcare, and I do my courses with World of 32 and independently as well. So these are the few cases which I did back in 2010, and it's simply put, these are the cases which I've learned, which have taught me what simple and complex endo is. And sorry, and you can see different curvatures maintained. And let's see the first case. If I tell you this was done with hand files, but the taper is maintained, the filling is good. But the problem is that it took me 3 hours to do this. These are the cases. They have been done with pro tapers, Carvo files, K3s, hero shapers. You can see these hugging roots and the sealer. But there, once upon a time, I was a fan of making sealer puffs, but now I don't believe in them much. This is a case of extra root in the distal of a molar. And there is something very interesting in this case which you will now see, and you can see this broken file. So I would say, see, everybody makes mistakes, but the thing is people only show their good cases, including me, on FB. So don't get fooled by the dentistry shown in FB. Some of them are really good, some of them are really crap, but you have to do it yourself. You have to learn yourself how you're going to do it. So let's move ahead, and we missed a slide there. This is one of the retrievals I did with some of the modifications, like using a simple barrel of 20 gauge needle, engaging the edge file which was there for the last 15 years. And the patient was a heart surgeon, and he was having on and off abscess there, and he was worried about the crown. He wanted to change it to more aesthetic crown. Then we had to retrieve and save the tooth. So one main lesson is why work so hard to do such kind of innovative things, or save the tooth. Well, I'll tell you very frankly, in anteriors, saving a natural tooth, in fact anywhere, is better than placing an implant. It's a highly skill demanding thing when it comes to an implant in an anterior zone. So in your practice, till the time you can save the natural tooth, especially the anteriors, go for them. You can save them by endodontic surgery, by non-surgical treatment like this. And all of these cases are there on Facebook. This is another case where I retrieved a file. It's just that, and these are the aesthetic cases I've been doing. Though I've been learning in it, and these are cases which are like 8 years old, 10 years old. Now my major focus is on, learning and treating people and teaching people. This is composite veneering from 4 to 4 or 3 to 3, I don't remember. 4 to 4. This is the diastema closure. This is veneers. This was a learning case, but this is not today. It's not about aesthetics. These are all Emax veneers. Now, from there, I have reached to this point with time, with patience, with practice, and I'm sure you all will be there. So, and I do implant practice as well. I've trained myself, and from the books, I believe in books, and some few good courses, and anywhere I believe ki if you really want to be successful in dentistry or any other profession, you simply have to love that. When you give love to something, you get love back to yourself. And if you love dentistry, that is wonderful. And even if you don't love dentistry but you want to do good in it, you can always fool yourself. Just make sure that you tell yourself that you are in love with dentistry and you are passionate about it. The more you keep saying to itself, one day you will start loving it. And I'm sure that you're listening to this video because you love it. And this is the SRT of RCT, because I was doing a lot of root canals when I was young. Young in terms of dentistry, not as young as SRT, which is Sachin Ramesh Tendulkar. So one of my students came up to me from the course and he said, you are SRT of RCT. So I thought this is a good line, I would keep it in my courses. So that's why I did it. And finally, all you need is love in dentistry before I get going. So this was a small introduction. These are the courses, that's my clinic, these are the participants. There are only two major principles which I go about in my life, and is work hard and party harder. There is nothing wrong in it. But if you don't work hard and you just party hard, I'm sorry, you're not going to get there. I'm also a motivational speaker. You see, I've been taking a lecture on that. I'll make a video and upload about that as well. Okay, and just me. And the other principle is, always stay young. 18 till you die. So when you stay young, you keep learning new things. One of the pictures shows the Khardungla pass, which we did on my small Swift in 2011, which is the highest motorable road, and I keep playing tennis regularly. So do that. Apart from endo, you should be doing all that as well. So work hard, party hard, and 18 till you die. That's the basic principle. And I am not going to go on this video because it's going to take time. So let's get to the point. Let's get to the point. And what is the point today? First of all, so we are back in business, I feel. So the first chapter is about, before you do endo, what is endo? What does endo means? Endodontics means. N means inside. Dontics means tooth. So what is inside the tooth? It's the pulp. So when we are doing endodontics, we are basically treating the pulp. We are basically dealing the pulp. So it is very important to know the fundamentals of the pulp. Unnecessary, I see a lot of doctors, a lot of dentists doing endo, and they have no clue what they are doing. They have just no idea what they are doing. So let's just go and, listen to the story of the pulp, what pulp has to give us. So pulp is a small tissue with really big issues. This is the thing which troubles you when the patient comes back to you after the first appointment, and the patient says, this is very painful, what you did last time, it was not hurting here, when I went home it started hurting, just because you're not considering the pulp at all. You are just worried about how your fascinating rotary files, your microscopes, how good canals you can see, or how your files can reach to length and how well your pixel kit is working. But you are not worried about the pulp. Most of the time when I see freshers, they just don't know what they're doing. So keeping that in mind, let's listen what the pulp has to tell us. First thing first, we should know what is the goal of endodontics. Why do you do endo? What do you want to achieve? And I'm sure 90% of the dentists, they don't keep the goal in mind and they just do endo blindly. Especially in my country where I see people writing treatment plans instead of diagnosis. I don't know how it works for them, but this is how it should be throughout the world with everybody. Everybody should know the goal of endodontics. So the goal of endodontics is simple. The goal of endodontics is to cure or prevent periapical pathology. I'll repeat it. To cure or prevent periapical pathology. Now in next slides I'll show you how to achieve this goal. So that means whether you do a single sitting root canal, whether you do a multiple sitting root canal, whether you do endodontic surgery, whether you do retreatment orthograde or retrograde, whatever you do, the goal of endodontic is just to cure the periapical pathology or to prevent the periapical pathology from forming. I hope that's clear. I hope now you have understood that why do we do endo? आखिर हम endo करते क्यों? So it's very clear now. And let me just put it here. And so this is a very good picture from Cohen, and you have to see and understand this picture and the phases the pulp goes through when it is challenged with bacteria. See in the first picture which is here, you can see the bacteria has just invaded the pulp. Alright, and there is very small inflammation in the pulp right here. Now sometimes pulp deals with these challenges and it maintains balance and survives because there is U-shaped arteries, arteriovenous anastomosis in the pulp, which we have now discovered with the help of higher microscopic pictures. And the pulp is really brave. It fights it out. It fights with the ingressing bacteria and does not let it enter the system. It does not let it enter the the pulp tissue. It keeps on fighting, but at a certain point when the microvasculature is collapsed in that particular region of the pulp, in this small region of the pulp, that is where it starts dying off and it's walled off, and that is where the limited pressure increase is there. In the past, when I was in an undergraduate and I used to read, and I was taught that once the pulp is challenged, the whole pulp develops excessive pressure and arteries here at the apical end are choked, and once they are choked, the whole pulp tissue dies and then it is infested by bacteria, and so that's why we do endo. Now they have found out that is not the reason. Pulp keeps on fighting, it doesn't die, the whole pulp doesn't die in one shot. I'm sorry for this notification. Let me just stop it once. So this is no more accepted. Now the research has said and what we have observed clinically, the pulp dies in parts. So you can see here this is called partial necrosis and there is inflammation here. At this certain point there would be patient might have pain, might not have pain, but I feel at this point it is beyond repair. You have to treat the pulp at this point, or the next slide where this is also a picture of partial necrosis, bacteria then cross into pulp chamber and the canal, but you have to notice there is no periapical lesion. So in this 1, 2 and 3 conditions, what we are doing is we are preventing any periapical pathology from forming. Okay, so this is the first goal, prevention of any periapical pathology if the patient comes out in these 3 conditions. If the patient doesn't come and it keeps on going and going and going and it reaches this stage where the whole pulp has died, the pulp has necrosed, the whole chamber is filled with bacteria and it is going in the periapical tissue. Now the lesion has formed. Body is trying to fight, body is trying to wall off the infection from reaching the other points of the body, and this is where we are curing the periapical pathology. So in both cases we are doing endo, but in one of them we are preventing from periapical pathology from happening and one where we are curing. So one very important thing we have to understand, that once you have diagnosed irreversible pulpitis in these 3 cases or pulpal necrosis, you are simply doing a pulpectomy, right? You are simply removing the remaining pulp, cleaning the canal and obturating the canal, the filling of the canal, so that there is no development. So the basic understanding is you can easily finish these cases in a single sitting. Okay? So understand, and 90% of the cases come at this point. But what we do instead of this, we go inside the tooth, we file the pulp, we infect the pulp, we put our files, already the pulp is inflamed, and we put our files and irritate the pulp and we increase the inflammation, and on top of that we place calcium hydroxide and close the tooth. Now what this leads to, the calcium hydroxide is highly caustic, and you have not diagnosed the case as a pulpitis case. You have simply written your treatment plan as root canal treatment. But then the approach has to be different. If you place calcium hydroxide in these 3 cases where the pulp is remaining, patient is going to have severe pain for the next 3 days. And trust me, it's not going to help your practice. Patients are going to say that root canals are really painful. But that's not the case. It is a misjudgment from us. So this is what I realized in my practice. This is what I initially used to do. But then if you know the cases of pulpitis, the irreversible pulpitis and pulp is in there, treat it as a pulpectomy, remove the pulp tissue, clean the canal well, make sure nothing goes periapical, and you can finish the case. I'm not saying go tomorrow in the clinic and start finishing the case. But understand this, follow proper endodontic principles, the techniques which we are going to discuss in the future presentations, and you can finish this in one sitting. Now coming to the case where you have already developed lesion. Sometimes this patient will come with severe pain, with swelling, with abscess draining. You have to cure this now. Now what you do, you clean in one sitting or 2 sittings, and then you give calcium hydroxide. Okay? Because now you are curing the periapical tissue, the periapical pathology. So that's how you have to divide your cases and approach them differently. Make sure nothing goes. We will discuss all that. Alright? So I hope this is clear. If this is not, you can ask me again in the comments and I'll help you out. Let's go to the next slide. So this is basically a picture where we are talking only of these cases. Don't confuse it with the pulpitis cases. These are the cases where you have periapical lesions. This is the case type 2. And you can see how this is called the Cornfield diagram. And it's a very beautiful diagram with Dr. Cornfield, and it explains it beautifully. He says, let's imagine in this case that this is a mountain pass. And our root canal apex is a mountain pass. And this is our body's defense. And this is a bacteria living in the root canal space. So, just a moment. So the bacteria is living in this space and our body is defending it and trying to stop it from entering the system or the blood flow of the body. So this is the case, and let's see another picture. So patient usually asks me why, give me medicines, it can work. Then I tell them that body's defense cannot enter through this pass and kill the enemy. So it cannot enter here. So what we have to do, you cannot, help with medicines. We have to go in and we have to help kill these bacteria and help the body to heal, whether from our sodium hypochlorite bombs or our cleaning and shaping. So that's how it is. So it makes you understand and makes your patient understand. So we have to go in and treat the case, and this is where we are lead. Once you clean it, the body's defense also goes away. So it takes time though. Sometimes people will come, the students will come and ask me, sir, we did a root canal in this case, but the periapical lesion is still there. But it can be a healing lesion. It can be body's trying to form bone there. So the lesion is not going to heal in 1 week or 2 weeks. It can take 6 months, it can take 1 year, it can take 4 years. So it can take that much amount of time. So you don't have to worry about that. If the patient is having symptoms, that means the canal is not clean completely, it is infected. So I hope you have noticed something very particular in this picture. And that is this one guy hiding here. So that's why I say when we do endo, we disinfect the canal. We do not sterilize the canal. You know what sterilization means. You have to remove the tooth out of the socket, put it in autoclave, sterilize it, and then put it back. And that's very possible, right? You can do that. So there is something very noticeable, and this is this bacteria, and this gives rise to two school of thoughts. There are a set of people which says that as we can only disinfect the canal, we should simply, after reducing the number of bacteria, minimizing it, and where we cannot go, like let's say this is a dental tubule and there is a bacteria, let's just fill it with sealer and the obturating material. So this, and one side is sealer and obturating material, and the other side of the root is the cementum. So this bacteria gets thoroughly locked or entombed into the system, and it cannot get out. So this is one school of thought. So this school of thought says if you can achieve this in one sitting, if you are that good with your technique, you can actually do single sitting root canals in these kind of cases as well. But I would say if you really are, a newcomer and want to start with single sitting root canals, don't do single sittings in these cases. Just do it with pulpitis cases. Don't do it in these cases. All right. So, and the other school of thought says just disinfect it completely, remove as much, and keep multiple dressings, give multiple intercanal medicaments like calcium hydroxide, or some people say triple antibiotic based. I personally prefer calcium hydroxide with chlorhexidine for 1 week at least to minimize the number of microorganisms in the canal, observe my patient, and then do the obturation. That's how it is. So I hope the concept is very clear, what the pulp is, how it works out, and how to deal with it, and how to divide your cases instead of just running in and looking at Facebook cases, how beautifully they have managed the curves and everything, and it is I should be doing the same thing. I believe what you should be doing first is understanding the pulp, unfortunately, which is not explained in these cases. And I believe the basic is important, and we should take care of it. Something about diagnosis. I want to break for 2 minutes. Just give me a bit. So as I was emphasizing on the diagnosis part, as I told you, most of the time we are not diagnosing well. See, 90% of the cases are straightforward. You see caries, you do a vitality, you know that it is reversibly inflamed, and you need to treat them. Or they don't show any response. But sometimes in 10% of cases you will get very critical diagnosis. For example, imagine a case where you have a big bridge on lower 5, 6 and 7, or upper 5, 6 and 7, and there's a missing 6 or there's a missing 4, and the patient cannot pinpoint the tooth, which tooth it is. So it becomes very difficult. So the purpose of diagnosis is to determine what the problem the patient is having and why patient is having that problem. Never rush. If you can't see the symptoms and you can't recreate those symptoms on your dental chair, do not start your endodontic treatment. Be very clear and be warned about it. If you don't see or recreate the symptom or the complaint patient is having on your dental chair, in the tooth, do not start endo. You are going to be in trouble. That is for sure. So never rush. Do all the tests. Do simple palpation. This picture is just to tell, don't palpate, with that backhand of your mirror when the patient is already telling you there is pain. Just feel it with a finger if you want to make sure which tooth it is. Okay, that's how you do. Never forget to palpate the periapical region of the patient and palpate on the apex of the root. A lot of time I have seen freshers, young dentists missing this point and just being in a hurry to do the next step, and your heat test and your electric pulp testing and your cold test. So I believe the cold test is the most important test, and you should all have an Endo-Eyes, whichever company you have. This is from Hygiene, and you should always have in your armamentarium. It sorts out so many cases for me. And you just have to do a vitality test, and before you do it, explain the cold test to the patient. Tell the patient that whenever you feel any sensation in the tooth, just raise your left hand. The higher you raise it, I'll know the intensity, mild, moderate or severe, and the time, and till the time you leave your hand up in the air, I will know the duration, and both of them are very important. So first thing you do, let's say you are diagnosing a left lower molar. So first tooth you will do would be the right lower molar, then the opposite upper molar, and so that the patient knows what a normal feels like, and you know that it is not a pain from any other tooth which is referred to this tooth. So now you have done the normal, and now you do the abnormal, the tooth in question, the molar in question. So that's how you do it. Never forget it. Always explain your test to the patient first, and then you do the test. I don't advise this, though I designed this to simple innovation. Took a guttapacha tube, drilled a hole in it, put a toothpick half of it, and then we used to do the cold test in our institute. So now we have stopped it because the water used to flow on other tooth. You have to isolate them, and then you will get a false positive. So endo ice is recommended. This is simply something we designed, and now we don't follow it anymore. Another use of these this ice sticks is when we give palatal anesthesia. We numb the palatal side with this ice, and then we inject, because we know the palatal is very painful, and we want our patients to have a painless endodontic procedure, and we want the tooth to be numb, and we want the anesthesia to be very painless. And this is small tip about it. And whenever you have a periapical abscess, whenever you have, always trace, always trace. Never do this. Never, just see the periapical abscess and go for it. Always trace it. And this is how you do it. And just see the tooth looks like 5, but when it is traced, it turns out to be 4. Sorry. So as I said, whenever you see an abscess, I have seen hundreds of cases where abscess was draining at 5, and when I traced the abscess, it was going to 7. I remember there was one case where there was a bridge in 5, 6 and 7, and the abscess was draining at the apex of 5. And it was very easy for me to open the 5, go through the bridge and treat the 5. But I thought, always, it's a rule with me, I would always track the abscess with a 30 number GP point or a 25 number GP point, 2%. And I'll put it into the sinus tract, and when I took an X-ray for that, I found out it was not the 5, it was just going to the 7. So basically the pus will take any easiest route out, and it can drain in 5 or any other tooth, adjacent as well. So always trace the sinus, never just work blindly. Sometimes you will see extraoral sinuses as well, especially in rural part of India. Patient doesn't come to us when it is starting, they just linger on, they take medicines which are just available over the counter, and then these kind of cases come. And one thing, remember, don't do anything from the outside. If you do any manipulation of the sinus on the skin, it is going to leave a bad scar out there. And I have a very, very good story regarding this case. So few years back, I had a patient, and she was a very affluent 40-45-year-old lady, and she had an abscess right here, draining here, somewhere around here. And for 2 years, she was suffering with it. She has gone to ENT, she has gone to 10 other dentists, she has done a CT done for it, and nobody could trace it. She was given so many antibiotics for it that she developed ulcerative colitis, and her story was just horrendous, and I really pitied. And then that case came to me, and I just saw the CT, and I could see the canine was really long, and the root of the canine was a little buccal. On top of it, she had a 4-4 bridge. I don't know why, but she had a 4-4 ceramic bridge, and I was quite sure that because the 3 has the longest root, the canine has the longest root, and that's why this sinus is draining extraorally. I simply drilled a hole in the bridge in the canine and removed the guttapercha. It was already treated. Cleaned the canal all over again, irrigated it very well, and gave her a calcium hydroxide. And she had very ugly looking sinus, all the abscess on the external surface of the skin. And she was really mentally in a very bad state. And trust me guys, 15 days, this extraoral sinus was, something like this, had healed. And I'm telling you, for the patient we were got. And I changed one dressing of calcium hydroxide and it was gone. The whole skin healed and everything was fine. And for the patient, we were got. So develop your diagnosis. Don't just give antibiotics for everything and anything, especially in India. And I don't know about any other country, but this is where I practice. And this is where I've seen people writing antibiotics just like that. Please don't do that. Treat the cause, treat the problem. Don't trust just on medicines. This is the whole point of me doing this presentation, so you can understand. You have to understand that the bacteria is inside the canal and there is no blood supply. Even if you give n number of antibiotics, it's not going to enter the tooth. If it settles down for a few days, it's going to reoccur. If you can do it, do it. If you can't do it, refer to your colleague, refer to your endodontist friend. Today we see in India, people come to your clinic to work. Call them. But please, don't prescribe antibiotic just because if you see a sinus or pus draining. Treat the cause, Okay, it's not right. So this is one thing. One another good story I have, which I would like to share with you. If you have time, obviously you're listening to me, so you have time. I got a very young patient, and let me see what's coming up next. Yeah, this is a very good thing. I have something where I want to talk about cracks, and this is the story which really fits here. And this patient of mine, he's I think 14 or 15-year-old guy, and upper canine had 2-3 abscesses, small abscess in the vestibule. And I traced it and it led to 4. And I thought 4 is the reason. I started the 4. And when I started the 4, the patient started jumping as it's a vital tooth. And I was in shock. I was like, how it can be? The tooth is vital. Patient is having abscess. And I just numbed it and it was tender and everything. And how can it give symptoms of having a pulp inside the tooth? And as I was proceeding, I was just exploring and I found out a white line which was going from mesial to distal of this 4. Patient had a fracture which was going to the root, and because the fracture was going all around the root on the premolar, something like this, so he had an abscess draining from this point, he had abscess draining from this point, and maybe from this point. So he had multiple abscesses draining, but the pulp was vital. The bacteria was living inside this crack line. So that's the reason. So that day I learned, whenever you see multiple abscesses, vital tooth, suspect a crack. If you see abscess both on buccal and lingual of a molar or any other tooth, suspect a crack. And when you see a crack, it's very difficult once they are below the bone to treat them and save that tooth. So if you start your root canal, start showing your wonderful skills in trying to saving this tooth, you are in trouble. So always look out for the cracks. You can see this radiolucency which is going like this, and this tooth has a post and a cantilever, and a process is creating unfavorable non-straight forces, and you are up for a crack. So keep your eyes open. Don't try to retreat all these kind of cases. This is one of the very interesting cases. Patient had a bridge, and we planned an explorative surgery because we were thinking that there might be a crack in this 5. And you can see the whole lesion out here, right? Once we raised the flap, patient was 70 years old. He didn't want to change the bridge. So we planned in endodontic surgery for him. And you can very well appreciate after I cleaned the granulation tissue where the crack is. You can see the whole line right in the middle. That's a vertical root fracture. That's a vertical root fracture right there. We did something innovative for this case because patient was not filling for anything else. We just removed the root, extracted the root, chopped the bridge, cleaned the bridge, made it a hygienic pontic, and filled the underside of the bridge with composite and finished it nicely. So that's how we dealt with this case. Alright, let's go ahead. So when you see a canal, these pictures are from our book Pathways of Pulp, Cohen, and these are not my pictures, I've just taken them for reference. If you see a canal bigger than the other canal, like in this, the mesial canal looks so wide, distal canal looks so narrow, so this is also a sign of a crack. The whole tooth seems to be floating. Suspect a crack. Suspect a crack until you find good, strong perio reasons. Perio is good in all the other teeth, if not bad. So suspect a crack. Always walk the probe along the side of the tooth, and once if it is dropped somewhere, that's called walking the probe. That is because there is crack and there is vertical bone loss. That's why. So when you get this kind of thing, suspect a fracture. Suspect a crack in the tooth. So these are just jokes when I used to take break, when I take it live. Now something about the referred pain which I see a lot of dentists missing. So this whole presentation is about clinical. I'm not going to go in depth, but if you find this kind of cases have been there in my practice and I have dwelt with them, I made my mistakes, that's why I'm sharing with you. See, this is also a diagram from Cohen, and see this. If you see the nerve coming from the maxilla is ending at this point in the nucleus, central nervous system, and see it gives collateral. So that means pain from here can also be referred to this point. This is the basic idea. This is a very important diagram. This diagram I really like. You can see these two nerves starting from this point, which is upper molar side and lower molar side, maybe the second or the third molar, and then you trace, and they end at the same point in the nucleus. So most of the times I have seen patients where we have pulpitis in lower molar, but the patient is telling it's in the upper molar. And sometimes it's the upper and the patient is telling it's the lower molar. Sometimes you have seen it, you might have seen it in the third molar case. The pain is in the upper third molar, patient is referring to the lower third molar. And this is the reason, this is the fundamental reason why it happens, and especially in this region of the face. So I'll tell you one very interesting story in the era of WhatsApp diagnosis, where your relatives ask for your for your advice, and one of my relative, he was in another city, and he was having severe pain in the lower arch, I don't remember right or left, 5, 6, 7, and he had a bridge, a long bridge, 4, 5, 6, 7 were crowned, I don't know for what reasons, 10 years back, and he was having severe pain, typical pulpitis pain. And he was showing to a local dentist, an oral surgeon there, and this oral surgeon removed the whole bridge, advised root canals in all the lower ones, but the pain was so severe, and the patient, my relative, he could not bear the pain. The blood pressure shot up. He was admitted to a hospital. He was given centrally acting painkillers, IV painkillers. And then when he was not able to find a solution, he had sent me his OPG on WhatsApp. So we have to suffer with this WhatsApp diagnosis. There is no way, and we have to help them. They are our relatives. If you don't, in India, you know how they are going to blame you. That you think of yourself too much. Let's get back to the story. Let's not go somewhere else. So he sent me this OPG on WhatsApp, and when I saw the OPG, I saw an upper 8 which was grossly decayed, carious, and I told him immediately, see, whatever you're doing with your lower arch, don't do anything, just ask your oral surgeon to remove this upper 8. And he told me that the pain is in lower. I just told him, see, this tooth you're not going to use, just get this removed first. I am quite sure that this is the reason for your pain. But he kept on arguing. Then he went to the oral surgeon, and then oral surgeon, I had to convince that oral surgeon so much. Sir, please extract. He was a senior oral surgeon. Please extract the upper 8. It's the upper 8 which is causing my patient or your patient pain. It is not the lower arch. But he wasn't ready to listen to me. He said, I'm an oral surgeon, I know better. Absolutely, you know better. Just do this much. I had to beg and plead. And finally, he extracted that tooth. The patient was pain-free within that half a day once the local anesthesia wear off. It was that simple. And whenever I meet this relative of mine in any party or any social gathering, he always comes and praises me. He says, the pain was in this hand, and he advised to treat this hand, and I got my results. And that's amazing. That's amazing. And I didn't have this inborn in me. It was just the fundamental knowledge. And that's what we have to go through. We don't have to be amazing. We just have to read the books. You just have to read the books. That's it. And you can be God for patients. And I don't say you play God, but that's it. That's the simple thing. So moving ahead with that, I know I am a little bit of storyteller. You can forward the video when you're watching it. So this picture actually helped me guide. Now, other common thing I have seen is the pain of muscular origin, MPDS or any muscle tenderness getting referred. So always when you are not able to diagnose, your teeth are testing vital, go for palpation of muscles. You can see that anterior fiber of temporalis, when they have pain in them, it is referred to the anteriors. When the middle fibers to the premolars, and the posterior fibers, pain will be referred to the molars. So always keep this in mind when you can't diagnose, and especially cases where occlusion is poor, bridges are there, do palpate the muscles as well. I would suggest palpate in every case, but whenever you're not finding, see masseter pain may be referred to the ear. These diagrams are from Ingle, 6th edition. You can refer to the book and further read about them from the book. So you can have sometime pain in masseter, which is referred to the tooth in the upper fibers, in the lower fibers. So you should know about it, you should read about it. I would advise refer to the book and go through this chapter. And though that was about pain and that was about referred pain, sometimes there will be endodontic emergencies in your clinic, like the way there is pus collection and the sinus. You don't have to always do, incision and drainage. You can just open the tooth, take a file, create some path, take a file, like take a sterile file 1 mm beyond the apex, like 15, 20, 25 or 35 if the apex is wide, and give the path for the pus to drain. So that's an emergency treatment if the pus drains, and the patient will have relief. On the other end, if it is a pulpitis pain, patient is having severe pain, you have to remove the pulp. So this is about incision and drainage, where I'm not going, I don't do it much. Now this was all the fundamental, all the basic before you touch your case. So trust me guys, before you touch your case, do know about all this, read more about it. This is the basic I have given you in a nutshell, what I can help you with. This is what you commonly face in the practice. There are a lot of other things which you should know. So now from this point onwards, I'll be talking about the main therapy part, how to do, what to do. Once you have diagnosed your case, once you know which tooth it is, once you know it is irreversible pulpitis, or it is chronic periapical abscess, or chronic periapical periodontitis, whatever your diagnosis is, and you will go to therapy. So we'll start talking about it. Okay, so let's go to the first step of endodontic therapy, which is access cavity preparation. Now, according to me, access is success. If you have done a good opening in the coronal portion of the tooth, which we call a coronal cavity or an access cavity or an endodontic access opening, and you have made the right access to the root canals, that determines all of your success. It doesn't matter which files are you using, hand files, rotary files, this XYZ company, it doesn't matter. If your access is wrong, your files are hindered, they are deviated, you are just doing it all wrong. And unfortunately, in this era of marketing, people market their files, people market everything, and the most important technique is ignored. So let's learn about it. Access is success according to me, as I told you. So if you see this triangle which I made, then the base is access. The base That means if your access cavity is good, your cleaning and shaping becomes easier. If your cleaning shaping is good, your obturation becomes easier. So this is the thing. What we do, unfortunately, we invert the triangle. We invert it like this, and then we land up with, your access being compromised, your clinic shaping more difficult, and your obturation even worse. So don't do that. Give time to access cavity preparation, how it is done. And let's see. So some basic component of anatomy you should know, that the whole tooth is divided into the root canal system. It's called, it divides into pulp chamber and it divides into root canal. So the pulp chamber combined with the root canal is called root canal system, or sometimes we refer to it in short as RCS. You can see the pulp horns, you can see root canal orifices, because all these terminology I'll be using. You can see lateral canal, accessory foramens, apical deltas and apical foramen. So all these terminology are basic. I don't have to go into detail with this. This is a Cohen diagram from the book Cohen, and let's go. And before you start your access, always read your x-rays. If you don't have good x-rays, don't go for endo. Don't go for endo if you can't read x-rays seriously. So for example, if you see here that if you see a canal, disappearing in the middle of it, that basically means that the canal is dividing into two. And it usually would happen in the upper first premolar or lower first premolar. So this is called a fast break. And if you take an angled x-ray, you can see both the canals. So that is a type 4 canal, which you should be knowing. Read the x-ray, usually the lucency should be in the apical area, but sometimes you can see it lateral because of lateral canal, which is quite rare. The second diagram is of a fast break, a canal dividing into two. The third radiograph shows you when the canal disappears in last 1 mm. That basically means either the canal is turning buccal or it is turning lingual. So why you need to read this in the x-ray? Because if you find this acute apical curvature, your rotary files, where it's rotating at a speed of 300 or 400 or 250, whatever speed, they can get engaged if there is no path, or they can break, they can create their own path. Anything can happen because this portion, just imagine the root is really thin. I'll talk about more. The other diagram shows, so always when you look at the x-ray, check out how your chamber is. Okay, this portion. Check out how your canals are, and any line like this which they have marked, which doesn't end into the canal, is not a canal. Which doesn't end into the pulp chamber, it's not a canal. Basically it's double lamina dura, it's the shadow of the lamina dura. So if you suspect that there is another canal, before you start digging the tooth, see whether that line on the x-ray is ending where it should or not. Okay, it should end in the chamber, then only it's a canal. Otherwise it's a lamina dura, image of the lamina dura. So paralleling technique, why it is important, and all the holders you should be having. This is the example, especially in upper 6 and 7, the image of the zygoma overlaps on the roots and we cannot see it clearly. So try mastering the paralleling technique if you want to do good endo. This basically shows the angulation in the upper. If you don't know which angle the x-ray is shot, just follow the palatal root. You know the slope rule, I'm not going in detail. Same side lingual, opposite buccal. So sometimes before going into the access basic technique, let's see if you have to do a root canal opening in an anterior tooth. So your starting point would be right in the middle, okay, this point. And then you make a cavity which is triangle, not just a pinpoint hole. So this is a triangle because of the two pulp horns, and you make it like 60% of your final size, not 100% but 60% of the final size. And first you can see the angle of the burr is like this. And once you have penetrated the enamel and you are into dentine, you have to change the angle of the burr. Always notice. And once you are in the chamber, then just feel where the overhang is and cut on the outstroke. Don't drill into the tooth. You are not going to create your own canals. Guys, let's be clear. Let's deal with what nature has given us. Let's deal with the natural canals and not try to create our own. So that's the idea. So this is simple technique when the tooth is, when the tooth is, non-calcified, and it's an easy access. Sometimes the lateral canal you will find this palatogingival groove. It happens in 5% of the cases. You will have a deep palatal pocket. If you are having a deep palatal pocket, and tooth might test vital or non-vital. Be very careful. The treatment differs for this. It's a specialist case or an extraction and implant case. It depends on your clinical judgment. But usually it's very difficult to check. So if we see the excess cavity depression in a premolar, if you draw a line from the buccal cusp tip to the lingual cusp tip, start from the X, start from the center. Don't make a pinpoint opening. Make a small round opening. Oval opening, buccolingually, okay? And usually you would find 2 openings or 1 big canal. And if you see for the molar, draw an imaginary line from the mesiobuccal cusp to the mesolingual cusp and a line on the oblique ridge. And you can start from this point. But don't cross these triangular ridges of these cusps. If you cross, you are going into the danger zone of perforation. Alright, you can go till here and it can look like this if required, but usually the distobuccal canal is coming out like this, so you don't have to cut so much. So I'll discuss the technique, how to go about it. And this is about maxillary first molar, and maxillary first molar usually would have another second mesiobuccal canal, and it is there in 90-95% of cases. I remember one case, and this was this lady, and she was very apprehensive. She would not let me work. She was very demanding, do this, do that, and I just wanted to finish a case. So I just finished a case, found my 3 canals, and just wanted to get out of treating her and wanted her to leave my clinic. So I treated her, all the 3 canals, good length, everything, did a filling, did a crown, and unfortunately she came back. She came back after 1 month with severe sensitivity in the tooth, and I knew what I'm going to face. So it doesn't matter what the patient is saying. Whenever you are working, try to find the MB2. I opened the case, found the MB2, just treated the MB2. The pulp was inflamed in that canal. Removed it, obturated it in single setting, and we were done. Another nemesis is the upper 7. See, usually all the 3 canal will be in the same line. Sometime if you find 2 big canals, let's say your 25 or 30 file is dropping into your mesial canal, right to the apex. Mostly then there are 2 canals unless you see on the X-ray. So if you have 2 big canals, it can happen in 7. Something to remember about lower central and lateral, they do have a small lingual canal, this point. Alright, so it's always good to cut a little lingual on the cingulum side and see and check for the canal. Okay, always do that in lowers. And another very important tooth is mandibular molar. Sometimes it has 3 canals, sometimes it has 4 canals. A very important point to start would be, see again, don't cross these lines. Alright, don't cross these lines. And you can start from the central pit. I would start from here and I would create a triangle. Okay, like this. So that's it. That's where your canals would be. Another headache is the mandibular second molar. Second molars, both upper and lower, are real nightmares. Sometimes it can have 2 canals, 2 big canals, sometimes it has 3, sometimes it has 4, and the worst is sometimes it has a C-shaped canal. So this is a classification. You can go in the classification by referring to the book. Sometimes it can be a single one canal, one root, and this is a typical C shape. These roots are fused actually, but you tend to see the bone in between. So when the roots are really close, suspect a C. Suspect a C, and it's very difficult to treat them, and you might feel that this is going into a perforation, but it's actually a canal in the C. So the worst is where I've seen people creating problems when these cases are referred to me, that they are trying to find a canal into the C-shaped canal. In trying to do that, they don't realize that there is no canal. And in trying to find the third canal or second canal, they will perforate. Usually you would find this, the floor of the pulp chamber pretty deep in a C-shaped canal. So if it's going really deep, don't worry, just understand it's a C. Stop the case. You can, if you have the skills, do it yourself. If you don't have the skills, do refer to an endodontist. That's what I would advise. But don't take panga, don't take headache out of treating these sevens. So what are the simple steps which I follow in my practice of how to open? So steps in preparation, let's say the first step is penetration phase. It's like giving a feeling of falling into vacuum if the chamber is not calcified. Okay, so I would usually start with a round burr, and I would create a small cavity, and I would go for the biggest canal first. Let's say the palatal in the upper and the distal in the lower. So my direction of the burr would be like that, and you can see here my burr has landed into the chamber. Okay, and once you are inside the chamber, use a carbide round burr, not a diamond round burr. Use a carbide round burr and cut it on the outstroke like this. You can see the angle. This is very important. So you are just de-roofing the chamber. You are removing everything. You are de-roofing the chamber. All right. So what I have seen, there is a clinical tip I would like to share at this particular point. Sometimes patient would have severe pain, even if irreversible pulpitis cases, the tooth wouldn't be numb. You just pick up a new carbide burr and don't rub your diamonds on the dentine. It produces heat, it just burnishes the dentine, and patient is way more uncomfortable. Use a fresh carbide burr, just go remove the dentine, and within 5-6 strokes you will find an opening of a pulp horn or the pulp chamber. And once you are there, you can always give an intrapulpal, though it is very painful. If you can use the X-tips, intraosseous, LA or other form of local anesthesia, go for that. But last resort, if nothing is working out, use a fresh carbide burr, find the pulp horn opening, and give your intrapulpal. Do warn the patient. So this is the second phase. The third is the finishing and the flaring phase of the cavity. These pictures are from the book called Kasluki, and you can refer to the book for further reading. And I would always without fail use a safe end burr. Now my assistants, sometimes they don't know, they feel the burr is gone, they will throw it in the dustbin, said the burr has lost its diamonds, but that's not the case. It's in India we get it on the name by EX24, the manufacturer is Money. You can have it from them. Even Dentsply has it, even Coltine has a kit for it, so you can ask for a safe end burr. The best part of the safe end burr is that no matter what, we are not touching the floor. कुछ भी हो जाए, फ्लोर को टच नहीं करना है तो नहीं करना है. And that is because floor has a map, floor has guidance, and then we just make the walls a little bit flaring out. It's like this. So we use this burr and make the walls a little bit diverging, so that the light can come in, your instruments can come in, and you can keep one wall like this, so your file should go straight. It should not touch the wall, it should go straight, like a distobuccal for the distobuccal canal in the upper, for the distal canal in the lower. So also what matters in the shape and flaring of the wall is the angulation of the tooth. If your tooth is tilted, let's say a 7, and there is the missing 6 and the tooth is tilted like this, so the whole excess cavity also will tilt like this. If you may go and make a straight access cavity in that tooth, there are more chances that you will end up with a perforation. So these 3 burrs I will use. I would first use a round diamond just to make the outline of the cavity depending on which tooth I am working at. Then as soon as I reach dentine, I'll pick up a carbide and then I'll dig into the dentine with a carbide burr, and once I have a drop, I'll just deroof it. There's a small tip. You can use a long shank spoon excavator, put it into the chamber and feel where the roof is. So I always do this because it's like this room and we have to remove the roof. So you put the chamber, feel the roof, where the roof is. So the roof itself, the chamber itself is guiding you. So every time the cavity is not going to be trapezoidal, every time it's not going to be triangular. Sometimes you are working on an 8, sometimes you are working on a weird anatomical tooth. So just take your guidance from the chamber, and once you take your guidance from the chamber, your openings are always going to follow the anatomy. Your pulp chambers, your canals will always be in the corner of the room, in the corner of your pulp chamber. So take guidance from the roof, take a long shank spoon, endodontic spoon excavator, feel where you have overhangs, use the round carbide or use this one to just remove those overhangs. What I would suggest, the starters, the beginners who are just starting into endo, and they should move to a slow speed round carbide. When you are deroofing, move to a slow speed round carbide. Don't do it with an air rotor, don't do it with a high speed, so that you can feel it and remove it. Once you are good with it, no problem, go for it. I still do it. Sometime when I come across a calcified tooth, after my first phase of initial entrance, I know that I have reached the chamber, I would deroof it with a micro motor or a slow speed, what they call. So this is a very important tip, and sometime when you come across calcification in the chamber, you can use the slow speed to shave off the calcification as well. Or if you have the ultrasonic tips, you can use those. A carbide in slow speed always would help you. Go slow when you don't see the chamber on the x-ray, when you feel there's a lot of calcification, use your magnification, use your loops, use your light. I will never work without a loop and a light, at least. Microscope second thing, but all my dentistry is with loop and light. So go for it. If you want, there are a lot really good dealers. Now it is easily available in India as well. So this is the whole summary of the process, deroofing, and you can use GG drills to remove this part of what you call the ledge of dentine here, this point, so that you get direct access, so your file is not deflected. All right, or any rotary orifice opener like ProTaper has an Essex, the 8% in twisted files, or Hero Shaper orifice opener. I enjoy any of them. I would go for 8% twisted from Cavo because it's quite flexible. So you can do the orifice opening with that. Let's ignore this joke. So this is also the technique given in Cohen, and this is a very effective technique when you come across a calcified canal, calcified chamber, how to find your canals. As I told you, go with a carbide round burr, deroof it, and this is a DG16 Endodontic Explorer. You feel the canals where they are. Don't work blind. Don't try to see the canal. Even if you don't see them, that's okay, but you can always feel them. And then you take a small 10 number file, you put it into the canal and check for patency. As a scouting file, check if there is no obstructions, check for the curvatures, just feel it, just feel the canal. And then you take your orifice opener, enlarge the orifice so that later on the files can go in easy. And you take your safe end and give it a nice flare, and now you can see the difference in the angulation of the file. See, you have to see this file, how angled is this, and once you have created a straight line access into the canal, how straight the file is. So this will prevent a lot of rotary breakage, a lot of file breakage. If you keep going like this, it's wrong. Open the orifice, move the wall away, and then work in a straight line axis. That is very, very important, and no one is telling you, no dealers and no file dealers come and tell you this, but this is because I don't know what do they expect. They expect you to know this, And now you know this, right? If you're using an IOPA, you can use an IOPA to you can use an IOPA to measure the depth of the chamber in a calcified canal. Always have in your armamentarium one DG16 or multiple DG16s, but always utilize an endo. You know, I must have done more than 4,000 or 4,500 or 5,000 root canals in the last 10 years. Every case I would use it. Every case I would use 3 burrs for opening, this, and then endodontic spoon excavator. Use have in the armamentarium. They are available with GDC, they are available with U3D, any company, whichever you prefer. And something very important tip in when you're opening a lower molar, this is called law of symmetry. This is given by Paul and Dummer, I think. I don't remember the names, but this is given by in an article and also in the books these days. So law of symmetry basically says that if you have 2 canals and if you draw a line mesiodistally and both canals lie in the center, in the middle of the line, on the line, that means there are only 2 canals. But on the other hand, if you have a line drawn and only one canal is at the line and one is off center, then there is one more canal. Find that. Alright. Similarly, if you have a line drawn and both the canals are off the line from the central mesiodistal line, there are 4 canals. So follow the law of symmetry. 99.5% cases this is true, and it makes your work easier to find all this. So another tip when you're doing endo opening and you're using loops, you can note the change in the color of the walls and the floor. It's always different. So sometimes when I'm taking a course, people are doing RCO. I teach right from root canal opening, right from learning how to read the X-ray. I teach everything. So from the walls and the floor, if the color is same yellow, that means you have not reached the chamber. That simply means that. So when the beginners come, they are starting into endo and they are always confused. Even experienced people I have seen, they ignore these small tips, the small hints, and they feel they are like, go wherever and just chop off everything and find the canal. But I'm telling you, you never look for a canal with a burr. No. If you're looking for the canal with a burr, you're doing it all wrong. You're doing all wrong, my man. Don't do that. Alright. So notice this change in the color. You can very well appreciate the wall color of the walls and color of the floor. So this is one tip. So I do take all these things, and sometimes patient is in severe pain, and you can always reduce the height of your points. If you are planning a crown in this case, then always reduce the occlusion if your plan is to do a crown, if it requires whether it requires a crown or it doesn't require a crown, we'll discuss it in post-endodontic restorations in further series. But if it requires, reduce the occlusion. Now next thing is, sometimes you will come across and you will be treating a root. Always look, because the crown is lost, roots get tilted and you don't know. And once you start drilling, you land up with a perforation. And this has happened with me, and this happens with everybody. So feel it with your finger where the root eminence is, or take care in the X-ray, and then angulate your burr like that only. You'll see the angulation of this and see the angulation of this. This angle is parallel to this one and this one. This angle is parallel to the canal, which is more important, right? So just take care when you have tilted teeth, tilted roots, you can very easily perforate. So always know where the tooth is tilted. It's a small thing, but it makes the difference between a successful case and a failure case. Endo is beautiful, if you just do it right and you just follow these small hints what I'm talking to you about. Amazing. All of your headache, all of your what people run away. I have seen dentists, endo is such, laborious and this and that. It's just that, practice what I'm teaching today. Because a lot of freshers, a lot of dentists I see, they just practice blindly. They're practicing old techniques. They've never grown. Only few I see if they have given. Whoever I talk to, endo, what is there in endo? There is a lot in endo. Because few of your cases fail and you remove that and do a bridge, that is not right. If you can't do it, please call an endodontist. If you can do it, well, good for you. But we are always there to help you. Today I am taking this lecture so that I can help you all. So guys, please, let's do good dentistry, let's do good endo, and let's, bill the patient what we deserve, what you deserve, what I deserve. And let's take the standard of endodontics and dentistry higher in our country especially. So there's some tips. Sometimes you have rotated teeth, there is no harm in doing a facial opening. Okay, you have crowding, no point. We don't do facial opening only and only because of aesthetics. So if your patient you can manage, they're aesthetically not that demanding, do a facial opening. Don't worry about it. Alright? If the tooth is already broken, no need to go lingual. Just go straight in and straight out. It makes things simple. Similar thing goes for the treated teeth. And if you already have caries, all facial, obviously there's no question of aesthetics here. We have to treat it. There's no harm doing a facial opening. In fact, a facial opening in the anterior towards the incisal edge is more of a straight line than any other thing. So it makes our work easier actually. And some tips about when teeth are crowned. See, you can see this angle of the stump is different, angle of the crown is different. You see this? Alright, and if you follow that and the canal is regressive, it's regressed because of calcification, you will end up with perforation. So take care of this. When teeth are crowned, be very careful. Use your loupes and light. Either if you can remove the crown, if you cannot remove the crown, always magnification. And always go slow. Take care of the angle of the tooth. Use a microscope if you have. If you don't have, it's okay to refer out. It's okay to refer these few cases out, man. Now, these are some mistakes which people do. This is from Castellucci, I think. And if you see, this is one pinpoint opening. This is not allowed. This is wrong. Do the opening right, the triangular shape we have been talking about. Okay, this is one very interesting case which I did like 2 or 3 years back. Okay, tell me what all you see in this. What do you see? What do you see? So what I saw initially on my IOPA, this was my initial IOPA, was a lesion, poorly done endo, maybe a perforation here, and a broken angle here. Fine, I thought it's an easy case. Let me just go through the crown, and I started from the crown and I removed the gutta percha, gave a calcium hydroxide dressing, 1 day, 2 days, 3 dressings, 2 months, but patient kept on having multiple abscess on the palate. And then my doubt shifted. Then I advised the CBCT. And what I discovered on CBCT was something amazing. So there was a lesion for sure. There was a lesion here. But also there was a cyst. A non-odontogenic cyst. See how big it is. It has eaten up the whole palatal bone. So let's go back. So there was actually, if you see, now I saw a heart-shaped radiolucency, and this is nasopalatine cyst. So I treated the tooth. I treated the surgical treatment of enucleation of nasopalatine cyst. Sometimes what the point is that CBCT can be helpful in these kind of cases where you cannot get to a diagnosis. And I wanted to be sure before I raise my flap for surgery that it is a nasopalatine cyst. So we did treat the nasopalatine cyst as well as the periapical of this tooth. Okay, let's just have some fun. All right. So that's where you can advise a CBCT for your endo cases as well. In the West, they are advising it for routine cases, but we know our resources are limited. So if you come across this kind of case, you can go for a CBCT. Now the problem, what kind of, sometimes people will do a RCO right through the caries. Don't do that. If you do this, you can see where your filing is going to be. There is a shift, or the canal is not treated completely. Make an opening correct like this. Okay, don't work through class 5. I mean, you can work through class 5, not through class 2, I mean class 4 and all. Now check out this case. What's the problem? What's the problem? There's no healing. This is the problem. The dentist has left the pulp chamber intact for you to find and treat. And what he has done, what a lot of cases I see have been done, they are being treated through the pulp horns. They are not the openings, they are the pulp horns. And this picture shows after the removal of pulp horns. This picture shows how they have removed, cleaned it, and now you can compare this picture to this picture. Okay, I hope I'm clear. So don't do RCOs and canals and BMP and cleaning and shaping through the pulp horns. Don't get blinded. And I don't know, somebody sent this to me on WhatsApp. What is it? How is it done? Creating canal in bone? I don't know. Somebody just sent it, I just placed it here. And the last few things, that you can always go for a pre-crown build-up. And rubber dam I'll take in another lecture. So if you have tooth structure missing like this, you can always, keep some plumber's tape, white tape in the chamber, etch and build the wall, so that your application of rubber dam becomes easy. Secondly, it creates a chamber where you have reservoir of your irrigants, which helps dissolve and remove the debris. So it's always good to do this. If you can do this, do it. Okay, create the wall which is missing, so nothing goes into your canals. Put a plumber's tape inside the chamber and build the whole tooth. Okay, and you can use your it becomes very easy after this. All right, sorry, same thing. This is almost gone. Creation of a wall, retreatment. All right. So this is called pre-endo build-up. Now, this is a picture from my own practice, and the patient got a tooth removed, and we advised the replacement of the tooth. We advised the patient that, get this replaced. It is going to have, give you trouble, and patient didn't listen to us. As usual in India, they don't listen to us. They are their own doctor. They have, after all, they have Google. So Google will tell them what to do, what not to do. Their relative who are not doctors, they will tell them what to do, where to go and how to go about it, but they will not go to us. But this is a picture which very well defines, why they should come. This is the picture I show to my patients. And this patient didn't turn up for 2 years. And just see what has happened. Just in 2 years, he has lost. Sorry, you can compare this one with this one, right? See the problems. He has lost bone, he has developed caries. Here, this is painful now, this has tilted, and still the patient, after getting a root canal done for this tooth, has not turned up. But this is just a few patients who don't care for their teeth. But then you can always motivate them. I always try to motivate them and tell them how important their oral health is. And you can just help them, to make the right choice for themselves. But as dentists in India, I feel we need to do a little more. We have a lot of teeth to take care of. 120 crore people, even more, multiplied by 32. And then say we are a lot of dentists. If we were a lot, nobody would have a dental problem in India, but they are having it. So guys, come on, let's buckle up, let's do it better from here on. So don't grow up. This is my personal state, as I told you, 18 till I die. It's a bloody trap. So this will bring me to the end of part 1. I hope this helps you a lot. And if you have liked the video, I request you to please leave the comments. So I can improve in part 2, where will I be covering cleaning and shaping, irrigation. In part 3, I'll be covering obturation and post-endodontic build-up, rubber dams. So it is a complete course. I am giving it just like that, so that everybody can improve, everybody can do good endo, and everybody, has the judgment to decide when to refer, when not to refer, or call an endodontist in their practice. Endo is tricky, endo is challenging, it comes with experience, but if you were starting from here after my course online, and if you want to join us in Ahmedabad, you will start from here. So I will pull you up in your skills here, and then you will zoom. And there's no better practice builder as endo. Nothing is better than that. So if you do good endo, patient is free of pain, patient has painless treatment. It's amazing, because 80% of dentistry in India is endo. On that note, thank you very much for listening to me. Thank you for having your patience, and take care. You can always ask me a question in the comment section. You can message me. I'm always there to help you guys, and share it if you like it. Let others also learn. Bye and take care.